start. So thank you everyone for coming on. Can I just ask that you mute yourselves? You can all unmute yourselves at the end and ask Nozer and Shonali as many questions as you like. But for the time being, if you could keep your camera switched off and you mute yourself. Now I'm going to introduce, because some of you know Dr. Nozer Sheriar and probably also Shonali Sabharwal, but I'm just going to introduce them both. So I've known Nozer for a long time. He is one of India's foremost gynecologists, if he's not the top of the rung, but he's certainly top notch. He's attached to a lot of hospitals. He practices at Breach Candy Hospital, the Hinduja Kar and Holy Family Hospitals. Nozer got a gold medal in every single postgraduate exam he ever took. He was given the Young Gynecologist of the Year award by the, was it the American Association?
The Asian Federation.
Asian Federation of Obs and Gynae. And a few years ago, he was awarded the FRCOG honoris causa by the Royal College of Obs and Gynae in London. He has been a member of the board of the International Federation of Obs and Gynae, FIGO, the FIGO board, and he was the scientific chair of the largest FIGO World Congress, which was organized in Rio de Janeiro, Brazil, 2018. He's also a member of the Technical Advisory Group on Maternal and Child Health of the Southeast Asia region of the WHO, a member of the governing boards of the Guttmacher Institute and a Center for Analyzing Change, and co-chair of the Medical Advisory Panel of the Family Planning Association of India. Apart from editing 16 publications, publishing 40 papers, contributing 70 chapters to books, all in his spare time, Nozer. He has served as the Secretary General of the Indian Federation of Obs and Gynae, FOGSI, and President of the Mumbai Association of Gynecological Societies. And he is also participated in the amendment of the Medical Termination of Pregnancy Act in India and developed the National Comprehensive Abortion Care Guidelines. Shonali is well-reputed. I haven't had the honor of meeting her before today, and even so, it's virtually very well-reputed and knowledgeable dietitian, nutritionist who she incorporates modern concepts into traditional nutritional practices, I actually thought I would ask Nozer to come and Shonali to join him to do a teaching session for us, because I read a book that they've both written recently. It's called Finding Your Balance. And really, it's the whole idea is not so much to promote the book, but actually to speak to them, because it was such a fascinating book. I read a lot about the menopause and things, but there were certain concepts that made so much sense, that made me think laterally, and I thought that Nozer and Shonali should come and speak, because we've got a very interested group of people. You can see a lot of them are there, and we're always asking questions of one another on WhatsApp and looking at the evidence and saying, what do you do for this and what do you do for that? So I'm going to start off by asking Nozer, why is this book different? There's been so much media attention, Nozer, about the menopause, its effects, HRT with several celebrity doctors. I mean, lots of articles. You just have to, you go online and, you get a wealth of information. So there were already so many publications. So what made you decide to write this book, and what do you think is different about it?
So this book basically came from Shonali approaching me 5 years ago and inviting me to do this book together. Now, Shonali is a much published author. She has 4 books prior to this, very focused on different aspects of nutrition. And when we spoke, I found it interesting for 2 reasons. One, both of us have a lot of women in the midlife we look after, and they've always felt that they have inadequate information. And when they have information, they find it very confusing information. we looked at the books available to an Indian audience and really asked me, there's almost no book on menopause really available to the Indian audience. Of course, you can always reach out and get books from the global market. What I realized when I looked at the titles of those books was that they were very, very focused at looking at the menopause or whatever from one different perspective. They were either very medical or they were very non-medical. A lot of the menopause books we saw, and over the years, we both collected lots of books. And somehow there was a lot of medicine bashing in some of them. And some of them, they were just pushing a certain agenda. And we felt that this was, if two of us come together, two different voices, and we can somehow come to an amalgam of a doctor, a person who's fabulous with lifestyle and nutrition. Not easy, because we had to find common ground and common voice. Shonali's style is very personal, lots of her personal anecdotes. I think we managed to pull it off. Shonali, if you would like to tell us me why.
I actually first put the proposal up for this book to the editor, publisher, and my editor and publisher, of course. And they sent it back saying, no, this book would be better written with a doctor on backing it. The subject itself would be better handled. And of course, I only had Dr. Nozer in my life. So he had seen me through my life journey already, I think 10, 12 years. And he knew I was writing books one after the other. So I just mustered up the courage and asked him, and he agreed. It was just that. And it took us time to kind of get it to where it is today, because there was a lot of going back and forth, because we didn't know how we were going to marry the whole holistic aspect of diet and lifestyle, nutrition, and everything with a medical, with the medical backing of, what perimenopause is for women. And we didn't want it to be too holistic, and we didn't want it to be too medical either. And we wanted to fill it with stories, because I think my experience about writing is, there are stories in there, his cases, which are absolutely true stories. My journey, because I was sitting on the brink of perimenopause, brink of menopause, actually. So that's how, the book came about. And I think we've done a pretty good job. It's exactly what we wanted it to be.
It is. It's one of the few books that marries up sort of actually cases with, and then, there's always, it's so holistic in terms of, it's not just if Nozer is giving HRT, there's other stuff as well. But I'm going to ask you, Nozer, because we get, as I said, with our WhatsApp group is always finding patients with rare conditions. Can we give her HRT? Can we not? So right at the beginning of the book, you talk about this patient with 2 liver transplants who came to you. And can you tell us about why you chose to give her HRT? Because previously, anything that was out of the ordinary, and we used to say no HRT.
So Asmi, I've realized that if something is in the realm of scientific possibility and safety, it probably has to be the choice of the woman. So here was this amazing lady. I met her in her early 50s. I had been the obstetrician to her 2 daughters, a daughter and a daughter-in-law. Husband was the head of one of our multinational companies. And because of hepatitis, she had to undergo a liver transplant. The first was rejected. Incidentally, she had the liver transplants in Birmingham, though she lived in Mumbai. She was miserable with the menopausal symptoms when she met me. And obviously, you first try and do all kinds of alternative therapies. Who would really want to mess with the liver transplant? And then we talked about this. We also discussed this with doctors in the UK, and we finally realized that she had a right to be comfortable. And then we decided to put her onto the patch. The patch has been available off and on in India. At that time it was, but for her it wasn't a problem. She'd source it from overseas. And every few years we'd come to the discussion again and say, you know what, I think we now need to take a break. And she'd take a break and she'd be miserable. And she'd come back and she consciously continued to use the patch for 15 years. Now, I said in the beginning of the book that this was probably a total outlier and the wrong story to start a book with. It's there in the introduction. But what it also told me was that you have to, when you're a doctor, listen to the patient, listen to the woman, and work with her within science. I mean, obviously the patch is the drug of choice for her because it completely bypassed the liver. She stayed comfortable. Here was a woman who was very clear about what she wanted. She was not happy, and the symptoms of menopause just came coming back every time we decided to take a short break. So it's not something that would be there in the list of treatments when you have a patient with a transplant, but it definitely has to be there as an option to discuss with the patient if she so desires to use it.
How old was she, Nozer, when you started?
We started in the early 50s. We started in the early 50s and we went on to the mid 60s. Because of the liver, there was other therapies that we really couldn't shift to. And there was also, of course, alternative therapies we used. But at the end of it, you know, she was one woman who just needed that dose of estrogen.
And did she have a hysterectomy? Did you have to give her the progesterone as well?
So this patient had a hysterectomy prior to the estrogen.
So it was only the estrogen
when she was younger. That's right.
And what happened when you took her off it in the 60? Because every time you tried, you say she had symptoms. So after 15 years, had it?
Yes. So finally, when we took her off the patch, by that time, I think she somehow had come to a point in her life when she was through the most dramatic symptoms. And she was relatively more comfortable. I think that's when we put her onto vaginal estrogens and she stayed on those. And yeah, she lived for a few years after that. I think she lived to her early 70s and we kept her comfortable.
That's good, because actually these are the things that women are coming with. People are living longer, they're living with more comorbidities, and women are no longer prepared to accept that just because they've had a liver transplant or a kidney transplant, even a thrombosis or even a breast cancer, they're coming and asking, you know, for something that will help.
Yeah.
That will help. But anyway, that's very interesting. But I'm going on to something else that, you know, in one of your chapters, you've said that the first wake-up call, you know, that a woman is going to be prone to hormonal disturbance or might have more troublesome symptoms of menopause is the premenstrual syndrome. And the second is postpartum depression. And most of us are already aware, because in all the international journals now, they're saying that it's called reproductive depression. The women who have the most troublesome symptoms during the menopause transition are those who have suffered from PMS-like symptoms, or what we call PMDD, you know, premenstrual dysphoric disorder. And also those who've had postnatal depression. You know, if you could use some sort of predictor, this sort of, and they're grouped under the term reproductive depression. But you have said actually that seasonal affective disorder is also one of those. So can you tell me more about that? What about the links of this? And because that is not something that I was familiar with.
Okay. So of course, this is something that Shonali and me discussed a lot. And Shonali has a lot of work again with, most of her work is with medical conditions. You're right, it's totally understandable that you have these disorders of reproductive depression, and in some way, they have an association with significant hormonal change. I mean, let's look at it. What happens at the end of the menstrual cycle before menstruation? What happens after delivery when the hormones, when the placenta has gone and her system is yet to kick in? Similarly, it basically, I think, also suggests that there are women who would be prone to emotional lability. And again, this is something that I naturally don't have personal experience with. I work in India, and we don't have the seasons the way you would have in the UK. I do know from a lot of my patients and from a lot of friends who live in the UK that people don't feel their greatest in autumn and winter, other than the fact that you have the winter wonderland, which makes you feel good, but otherwise it can be pretty depressing. And I think most of these, we have a whole chapter on mental health. And we've taken a questionnaire and modified it. And when I was doing that questionnaire, I realized that besides assessing mental health in menopause, this is also looking at issues where women become more sensitive. This is something we found in our research, and that's why we put it in, because we did realize that this book is not just going to be read in India, but it's going to be read overseas. And someone who is afflicted with this disorder, if you can consider it that, and there's a name for it, so there is a disorder, when she comes to the perimenopause, will probably have more understanding and will try and prepare herself more. And if she recognizes, seek out help. So that's why we put it in there. Shonali, would you like to say something about the wake-up calls?
Yeah, I just find that, women who deal with trauma, and I've seen that common thread amongst my clients, that a lot of women who are dealing with trauma and have stayed in touch with me in their 30s, 35 plus, that age group, are also going through some sort of PCOS, PMS, all these things. They've started coming up now so much. And, this whole thing about these a lot of women come to me and say, for example, we crave sugar during our period cycles. And they feel low. They really feel low. They can't explain it. Like some women who've come to me have said that, we feel low now, we need to pick ourselves up, so we reach for that sugar, and I found that if they've stayed in touch with me, a couple of them, then I found that they have been having trouble around menopause. The same women. I've seen that over my last 15 years of seeing. And also women who are going through menopause, who are just like kind of there and are going to go through it, are also going through, like, they can't explain why they're feeling a certain way, but they are feeling a certain way. They're feeling blue, and then again they're reaching for the wrong things and they're eating the wrong things, and that's fueling this mental stuff that they're going through. And a lot of them who have had, for example, obsessive compulsive disorder in their younger years, now those symptoms start coming up at this time. I mean, have those kind of cases, So obviously, somewhere I find that there's this trauma, that they've kept within them. Even like when you're dealing with the cancers, the trauma that they're holding on to kind of surfaces at the times when their body is at its lowest. This mental stuff starts coming up, and SAD doesn't really help. The seasonal affective disorder doesn't really help, because it's our research pointed us in the direction that weather is such a big part, just being dark.
Definitely contributes to depressive.
And we in India don't face it, but I know in the West it's like really big, and I do have patients from there as well. And, they're not happy that someone's living in Wisconsin and they've got like 6 months of winter, it's like cold and it's dark and they can't do much and they feel blue. So it was very real then to us to kind of bring this all up. We knew our book was going to go not just here in India, it was going to go out to the West, and we wanted to talk about it. Trauma was a big part of what I do. The work that I do and deal with, because I'm dealing with a lot of lifestyle diseases, and they're very closely connected to what they're going through emotionally. And I know that. So that's a subject that we wanted to touch upon in the book. And I think we've done well with it.
So coming back to the,
we've actually put in a statistic, and at least we found that with PMS, depending upon severity, the 27 to 30% of women who experience significant PMS are going to have a stormy emotional symptomatology in menopause. So
That's right.
and that
Yeah,
chapter
yeah.
really tells particularly women preparing for menopause. Shonali always says, you always prepare for your next decade. If you're in your 30s, you kind of prepare for what might be coming. So you are better prepared. You kind of, get ready for it and seek help early rather than late.
Yeah, no, that makes a lot of sense. And now coming back to the premenstrual PMS or PMDD as it's called, women often find, I mean, you said some women, sort of take sugar around the time of their periods, but if you look at the RCOG guidance, the green top guidance, they've actually recommended vitamin B6 supplements as one of the treatments that can be tried. And then of course there are various sort of diets. So, I mean, bearing in mind that before this meeting started formally, we were talking about the fact that sugar is the enemy. How would you, but then these women are getting cravings for sugar around that time. And what sort of diet plan? Because there are a lot of patients who have the peak incidence actually of PMDD, premenstrual symptoms, is around the time of menopause transition when the hormones are fluctuating up and down, up and down. Sometimes the periods are coming frequently. So how would you, because a lot of these women, you can manage their symptoms, but you can't they can't get their weight down. And they are extremely frustrated. And just today I was reading, it was, I think, doctors.net, that GPs and doctors are giving, inverted commas, vague advice about weight loss, and patients are not happy with that. And I thought to myself, now what are we supposed to say? So is there anything specific? And, is there a magic bullet? Because women do want that.
Yeah. So here's the story. So you can wear one hat or you can choose to wear different hats. This is the way I look at things. So the one hat is, I'm going to eat clean 2 weeks before my period cycle, because if I eat clean 2 weeks before my consciously, right?
Can you explain what you mean by eating clean?
By eating clean, I mean you actually quit sugar.
Okay.
You actually quit sugary products. You actually make sure you're having 3 meals a day with two snacks plugged in somewhere. So you're eating frequently. So that's a lifestyle habit. You're not eating late at night. You're plugging in a whole grain at least at one meal, like a brown rice or a red rice or a black rice, or you're having, if you like quinoa, then you're doing that, something at one meal, which makes it, so you can do it at every meal, but if you do it at one meal, then chances are you're working with the principle of moderation. And you're also making sure that you're staying away from anything sugary, so like cola, sodas. So that's wearing one hat. So that's saying,
that includes artificially sweetened drinks.
Artificial sweeteners, except stevia, which is okay. But a lot of stevia now is being put in together with a lot of other sugar derivatives like maltitol, erythritol and stuff. And that's messing people's heads and thinking patterns. So be careful of where you're getting, what from. So trust the brand, I would say. So if you do that 2 weeks before your period cycle, chances are you'll go very well through your period. And you'll go very well even into your period, and your symptoms of PMS would be greatly reduced. If you're putting in some, and I've outlined that in the book, like some habits which are very good: eating on time, eating smaller meals, not eating late at night, not skipping any meal, not skipping breakfast, for example. But then if you want to wear many hats, right, you want to also do the sugar, but you want quick answers as well, like my weight's not going to be doing well, then I don't think you're going to get anywhere. If you're going to try and do everything and do a little bit of this and a little bit of that, so that doesn't work. If you are someone who has pointed out that, listen, I do go through PMS quite severely and I do have issues, so I need to make a correction 2 weeks before my period cycle, you will go through those symptoms better and you will have a better period cycle as well. But the idea
that gets you into the pattern of better eating, doesn't it?
Because yes, it does. Because you just get out of your period cycle and then, you kind of have a week and then you're back there again, right? So the idea is that you'll have, a woman's period is a huge discharge of the body, and it's basically a good cleanse that happens to a woman in her, it's good actually for a woman to have a period, right? So whatever you're going to eat is going to discharge more easily and give you less of the PMS-like symptoms if you're going to eat clean 2 weeks before. And by eating clean, I mean just that, like, what is your dairy consumption? Is dairy triggering you in any way? Are you relying too much on caffeine, for example, stimulants? Then you cut back maybe cut back from 3 cups of coffee to 1 cup of coffee. That'll still make a difference, It'll be a very subtle difference, but you'll start seeing it. So a lot of women who come to me with period pain always say that this eating 2 weeks before our period has really helped my period pains.
I think of that because my answer to that is actually to stop the periods and say you don't need periods. So I've either put in a Mirena coil or I give them the pill continuously, but we'll come back to that. But
So
anyway,
one thing that happened when we started doing this book is we started collating our personal learnings and experiences. For example, I wasn't taught in med school that women in their late 30s and early 40s are going to experience more PMS symptoms. It's something my patients taught me. I wasn't told that they're going to have more miscarriage. It's something my patients taught me, which is why when we wrote this down and we started offering suggestions and solutions, you will see it in the book.
Yes, I did notice that a lot of it was based on what the patients bringing their stories and their success stories and what worked for them. So that I found very powerful because
so these PMS symptoms start slipping in and taking more time in the cycle. Vitamin B6 I've always believed helps. I like to give my patients and I tell them it's your happy vitamin. And the moment you tell them something like this, it really becomes a happy vitamin and makes them feel better. So it's something that we have used. And now, of course, there is reiteration to say, well, let's face it, all of us have used evening primrose oil for the longest time. And I always say it's a gift from the UK to the rest of the world. So stuff like that. How much of it is placebo and how much of it is real, I'm not sure. But if it's gotten into the Green Top guidelines, there has to be some evidence supporting it.
Correct. Now, Nozer, in the UK, we have adopted the use of transdermal estrogen and micronized progesterone as first-line treatment when initiating HRT. But interestingly, I attended the International Menopause Society meeting in Lisbon and attend various menopause forums. And because of the shortage of transdermal products in the UK, they're actually saying that women, who are slim, who don't have any contraindication really, they're not at high risk, they actually could have oral estrogens. And I'm aware that the shortage of HRT is not unique in the UK, and in India, transdermal is not or has not been first line. So in your experience, can you tell us how you initiate HRT, what treatments are available to you and how you manage them? Because we are having to chop and change depending on what the supply and availability is here. And in consequence, what happens is because you get so used to gels and micronized progesterone or patches, you forget or you lose the experience that everyone used to have 20 years ago managing people with oral estrogen. So can you tell us what's available to you and how you initiate HRT?
So in India, I would have to say that oral HRT or MHT remains the mainstay. We are using more transdermal now, but if I was to poll a majority of gynecologists in India, the first line is oral. We had the patch a few years ago. Somehow it didn't work in India. There were reactions and they got pulled from the market. But thankfully, we have the gel. We had the gel earlier, but now we have a pretty steady supply of the gel. And on a case-by-case basis, like you just said, we do use the gel. I use the gel more and more now, though orals remain my mainstay. When I say orals, we are still using, depending upon different people's practice, either conjugated estrogens or we are using estradiol. Interestingly, cost-wise, India would be very cost sensitive because we don't have too many patients who can afford expensive treatments. And all this treatment is in the private sector. It's all out of pocket. So the most expensive, if I was to compare two pumps of the transdermal estrogen, which is generally what I use, sometimes more, sometimes less, it would be more expensive than conjugated, which would be more expensive than estradiol. So this is as far as estrogen is concerned. We too have moved from the traditional medroxyprogesterone acetate when it comes to MHT to either dydrogestone or
Do you
micronized.
get that as a standalone?
We do.
Oh,
but,
we don't have that as a standalone.
but micronized progesterone is more cost effective, interestingly, in India, and we have no shortage of micronized progesterone. The pharmaceutical companies who've been pushing it in obstetrics and who've been pushing it in a big way with infertility have made sure that we have no shortage. And we've got lots and lots of companies. See, in India, we've got the advantage of a very strong pharmaceutical industry. And when you've got a lot of manufacturers, it also becomes very cost competitive, which is a bit of an advantage we have. So presently, what I'm doing primarily is I use oral estrogens. I use micronized. Micronized, I give my patient the option as to whether she wants to take it orally or she could use it vaginally.
Correct.
Patients decide. I do have more and more patients now where we are using the transdermal. The transdermal has given me the flexibility of the averages. Usually we start off with 2 pumps. Very rarely we bring it down to 1. There's a whole section in the book which talks about, the symptoms that estrogen creates. And there are some patients who need more than 2. I very, very rarely had to go above 3. Very interesting story in the book of the woman whose story is told in the MHT chapter, MHT to or not to do, showed me how a woman took charge. She decided what worked for her. She was amazing. So she would do 1 pump one day, 2 pumps the next day, watch her symptoms. I mean, a little too much manipulation, but it worked for her. If it worked for her, it worked for me.
We have got patients. That's very interesting that you don't go above 2 pumps, because we've had people going on to, I've had people going on to 8 pumps. Yes, seriously. And I was going to ask you, since you said, say that what would you do if somebody comes to you and says that, yeah, you've given me, I'm using the 2 pumps, I'm, some of my hot flushes and night sweats are gone. But a lot of them say, a lot of women say, I don't feel myself, or they feel that they should be feeling better. And I've seen people put them up to 8 pumps. In one case, it wasn't my patient, but I met somebody at the Congress who said that she'd seen a patient who had been given 16 pumps. And I just wondered where she got the body surface area to even apply it. So what's your advice on bumping up the dose, if somebody doesn't get relief?
So firstly, I do have a few patients who take 3 a day. I haven't had patients needing more. And if a patient did come and ask me whether she could have more, Azmi, based upon what you just said, estrogen is not the beginning and the end of the woman feeling well. You have to be looking at many other aspects, and we have a lot of other solutions for her. When someone tells me that they just keep pumping up the dose and pumping up the dose, when something doesn't work, I'm reminded of when we are in the OT, and for some reason, if your cautery doesn't work, and someone keeps pumping up the power and not checking, are the connections right, or is something wrong with your handpiece? And suddenly, if that cautery was to connect, you could have a disaster. Yeah. I mean, there are certain safety limits we have to set for ourselves. Again, there will be outliers. And in medicine, we do have the flexibility of dealing with these outliers with a reasonable amount of safety. So if I've used my 3 pumps, and maybe someday I might use 4, and if she is not symptomatically better, there's so much more we can do for each individual symptoms, whether it be vasomotor symptoms or urogenital symptoms, and use those. I mean, I've used vaginal estrogens in combination with MHT. Because if the vagina is going to take forever to respond, I'm not going to keep her hanging there and tell her, you got to wait for 3 months for the vagina to catch up. I will use vaginal estrogens. I will use MHT. I'll take a call after a few months whether the vaginal estrogens continue or not. And you could do a lot of other things. But I personally think that for each and every one of us, for safety, for each and every one of us, for in the patient's best interest, we have to set certain red lines and try and stay within them.
Oh, thanks. And the other thing I wanted to ask you was, you speak a lot about Tibolone, which I found interesting. And in the UK, it's dropped off, and it's dropped off for two reasons. One is there's this big push about this body identical, that if you give estradiol and micronized progesterone, that's an absolute fit, and they are identical with the hormones that your body produces, and that's natural, and there's been less VT risk with the transdermal. The micronized progesterone and dydrogesterone were found to have better breast safety. And then Tibolone seemed to have, there was a scare because there was a study showing that it increased the risk of stroke in older patients. Now, you said that after prescribing conventional HRT for 5 years, you offer them an option to move on to Tibolone. So can you explain more about that? Because I personally feel that Tibolone is an underused option in some ways. It had good breast safety. I know that there was a Liberate study which showed a recurrence in women who'd already had breast cancer, and there was this one study showing an increased risk of stroke. But in terms of, although it's an oral preparation, it doesn't have a thromboembolic risk. And can you tell us more, because you've been giving it a lot more, and you have a larger series of patients than we would have here. So can you expand and tell us more about that?
Yeah. So Azmi, Tibolone did have its day in India, and even in India, its use is on the decline. And I don't think it's on the decline because it's a great drug. I think it's on the decline because, firstly, the main Tibolone preparation made by the multinational was pulled from the Indian market. Fortunately for us, we do have 1 or 2 Indian manufacturers who continue to make it available to us, so we continue to use it. I would usually, if I have to start with HRT or MHT, I would usually prefer to go with estrogens and a combination of estrogen and progesterone if the woman has a uterus. I do this because I've sincerely believed that nothing works as well as estrogen when there is estrogen deficiency. But very often when it comes to longer use, and that's not too many patients. I mean, most patients after the first 2 or 3 years, and that's in our context in India, will finally say, okay, now I'm good to go off it, and somehow manage to stay off it. And there's 1 or 2 stories in our book as well. I remember this first story in the vasomotor chapter. Amazing woman. We used to call her Mrs. Sunshine in our practice. Walked in, bubbly, great, did her estrogens, and after a few years said, Doc, I don't want to go off this. And for whatever reason, whatever little bit of risk comes in after 5 years of use, I want to stay on it. And we talked about this as an alternative. And she went into Tibolone. So I would normally start off telling my patients, Doc, what do I do after a few years of HRT? Do I have to stop it? And I would say, no, we've got an alternative for you. It's a preparation called a steer. It's something that behaves differently on different tissues in the body. In fact, interestingly, if you were ever to see the mammogram of a patient who's on Tibolone, it would look very different from a patient who is on estrogen. I mean, the dense breast you will see will not be there when you're using Tibolone. So in fact, it kind of some way, and this is our experience, almost spares the breast and the endometrium. With the endometrium, if we used it earlier on, we would have breakthrough bleeding. But many years after menopause, that went away. And I would normally tell my patients, you could stay on this for quite some time. And I did have patients staying on it for almost 8 to 10 years after the estrogen, loving it. Remember, Tibolone also has, it basically goes into 3 metabolites two estrogen-like, and one progesterone androgen-like. And somehow, and this again is documented, there are studies to back it up, but this is also an experience. The feeling of well-being, and probably when it came to its effect on libido, seemed to be better than when you just used estrogen and progesterone. So it has a role to play. It's not first line for me. It is not something every patient of mine goes to, but it's something every patient of mine is told about and is welcome to stay on for many years after menopause if she wants to take Tibolone. That patient of liver transplant was not offered this drug because it was an oral drug, but for many other patients, it would be a great alternative to back up with.
So it's interesting that you are actually putting patients once they're older on it, and we shy away from doing that. Have you had problems in your older patients with stroke?
So Azmi, when I'm saying older, I'm probably talking about women in their 50s, not women in their 60s.
No, but
So,
they're carrying on. Would you have reservations about them carrying on with it in their?
So very often for us, our experience is much of our MHT starts in the late 40s. Probably
because in India you have an earlier menopause, yes.
45, 47.
Yeah.
By the time they're in their early 50s, they're ready to move on to something else. And by the time they get to around 60, they are okay with moving off. See, at the end of it, there are multiple reasons. Not all women want to be on a medication forever. Each and every medication involved with hormone therapy costs quite a lot. And though it's much cheaper in India than you would get anywhere else, thanks to the fact that Indian pharmaceutical manufacturers will always sell identical preparations in India, which are a fraction of the cost that probably would be overseas, it still costs a lot. So this kind of arrangement has worked quite well. And let's not forget, I still have, for women who want something and who don't want to take things which have potential side effects, because the first thing a woman is going to ask you is, what are the risks and side effects? And you would have to tell them the risks and side effects. But I also tell them the beneficial effects. For example, with Tibolone, I will tell them that while there is a very small reported risk of stroke, you've got tenfold benefit when it comes to your history of fractures. So everything is balanced off. Where you've got a small increase in risk to the breast, you might have significant increase when it came to reduction in risk of colon cancer with estrogens. So I think we've now got to start giving women messages, giving them information, telling them the truth in ways they can easily understand it, and then trust them to make the right decision. If someone has to take the risk, they have every right to know what the risk is and every right to decide whether they want to take the risk.
Right. There was a whole chapter you've written on genitourinary syndrome of menopause, along with symptoms of prolapse and stress incontinence, that are a huge problem for women. And Nozer, can you tell us about the surgical management of these patients, given that the vaginal mesh has been associated with complications? Because that's something that women are very aware of. As soon as they have, and you say, well, you need to have surgery, they say, well, I've heard about the mesh. And Shonali, what advice do you give to women with an overactive bladder? Because just recently we used to tell them not to drink caffeinated drinks and colas and sweetened drinks, but I got a bulletin from one of the North American menopause groups saying that actually now sweetened drinks, but drinks, this colas flavored and sweetened with artificial sweeteners actually don't seem to have an effect on the bladder. So Nozer, can you start off talking about the mesh and what surgery you offer them?
So in India, we had a very brief flirtation with the mesh. It came into us a little late and it went out a little early. We didn't really have, I did have a patient or two where mesh was used and where it eroded, and it was okay, but it's something that now in India, and Azmi, you trained in India, we pride ourselves on our vaginal surgery. So we pride ourselves on a non-descent hysterectomies. We pride ourselves on our repairs. We do sacrospinous fixations when we need to. So a lot of our work is done vaginally. We don't need to go laparoscopically or abdominally. So when it comes to prolapse surgeries, for prolapse have to be well done. They've got to be meticulous. You've got to create, buttress the fascia adequately. You've got to find the fascia to buttress, and you do a pretty good job. Sometimes it may be a good idea to give vaginal estrogens for some time prior to your surgery, so you help better healing. When it comes to stress incontinence, of course, today, for most of our patients, we've completely shifted to doing the transobturator tape, and it's done well. It's giving good results. It's giving us a very simple procedure with or without having to do a repair. And again, we interestingly also have indigenous tapes available who are 1/10 the cost of the international favorite and seem to give us reasonably good results. So we would always, the first thing that you have to understand is I have a lot of patients I actually have to tell not to go in for surgery. And pelvic floor exercises, pelvic floor strengthening is something we just have to pay more attention to. And this is something I'm going to pass on to Shonali after she speaks, because Azmi, as you know, every chapter is very strong on the lifestyle as well as the diet, which is written by Shonali. So we made a very conscious decision of mentioning this in every chapter. So Shonali, bladder.
Just before you go, Nozer, do you put in a pessary? You put in the ring pessaries, the gel horn pessaries?
So somehow we don't use too many pessaries in India. I mean, some people do, but not too many pessaries in India. We prefer just getting the thing repaired. Part of the reason would again be compliance, vaginal hygiene. I have occasionally, had to deal with pessaries which were forgotten, embedded, particularly in the elderly. And I think if today anesthesia is, the amazing thing about vaginal surgery and vaginal repairs is today with modern anesthesia, it's almost ambulatory. I mean, you do it. If you're doing a repair, she's home within 48 hours. And if you're just doing a vaginal hysterectomy, she's great within 24 hours. So no, we do have the pessary, but we don't use a lot of pessary.
So yeah, diet-wise, I would say when you're suffering with incontinence, is cut back your salt. If you can look at the kind of salt that you're eating, like are you eating rock salt, sea salt, Himalayan pink? Don't just use, table salt, regular table salt. Look at the quality of salt you're eating, because incontinence is deeply connected to kidney energy. So, you're going to be, if you support your kidneys, then chances are you can get it under control. Also focusing on your Kegel exercises, which we've taught in the book, do it right. Focus on them, actually do it in the tradition that I come from in yoga Pilates. We actually make you so conscious of them that you're even doing them unconsciously when you're in like lifting something, you're just making sure your pelvic floor is right there. You've pulled it up and, it's holding your spine together. So be conscious of that all the time. And I think there's a dedicated section where I've really focused on how to do it, like how to do it right.
Yeah.
And your brain kind of gets wired after a point to kind of tune in. So whatever you're doing, if you tune into your pelvic region and just pull up that pelvic floor, you're kind of keeping it strong all the time. So really focus on it. Don't just think that, I've forgotten to do it for 3 days. No, make it a part of your lifestyle. I think it's very essential for women to understand that. And also, don't do this extreme eating. In incontinence, what happens is I find women are doing they're doing a lot of stimulants on one hand, like coffees and teas and sugar and stuff. And then they are also running towards the opposite side, like they're having a lot of meat and they're having a lot of processed and they're having a lot of refined. So watch what you're eating, because if you're eating foods which are too extreme, that's going to cause some upheaval in the system. And then that's going to cause you to have more incontinence and not being able to manage it. I've personally seen that women who have focused on exercise and women who have focused on their pelvic floor have had less problems than women who haven't. So I think for younger women, it's really important to understand that incontinence is something that all my friends, we joke about it and laugh about it as women, that, it's happening to us in some degree or the other. And some are really bad and some are really okay with it. But we really need to focus on pelvic health for, keeping in.
And the weight comes into that as well, because
And the weight comes because,
the
if you don't
heavier
have
you are,
Exactly.
the worse the incontinence. Nocturia is linked with
Right.
waking
And
up at night is linked with weight as well.
Yeah, and also candida, people who have nocturia also have I've seen women who have candida have nocturia as well. It comes together. So then their gut health comes into play, then you rewind it back and you start looking at what's actually affecting women, and then their guts are weak, and that's when the whole candida comes up, and then they go into UTIs, so it's all connected.
Right. So this leads on to libido and sex, and I was happy, Nozer, to read that you recommended the use of a vibrator, because that's something I mentioned in my consultations and in the webinars, that people forget that apart from the pleasure aspect, it works as a therapy because it stimulates the pelvic floor muscles, it improves vaginal blood flow. I mean, how do you deal with women who complain of lack of libido? And I wanted to ask you about testosterone. Do you prescribe testosterone?
I do. So, Azmi, first of all, that was a chapter which came in because we kind of, should we, shouldn't we? And we said, no, absolutely, we should. In fact, we went one step further, and there's this amazing person by the name of Lisa Mangaldas, who does I think the best sex education. She's got a YouTube channel. She's just come out with a book called The Sex Book. And we got Lisa to contribute a chapter to our book, one of the 2 invited chapters. And a lot of it was on self-gratification. So when we decided to write this, yes, we did write about the vibrator. We thought that there are certain things we have to mention that people won't want to mention or ask about. And you got to tell them, it's okay, it's in the book. You're absolutely right. There's actual scientific evidence to show that vibrators have been used. One is to make the Kegels better. One is to make women realize what the pelvic floor and pelvic floor tone is and make it better. And there's also evidence to show that vibrators do improve the blood flow to the vagina. And maybe it's one reason why they also help with stimulation. So, everything has to be on the table when it comes to helping the person we are looking for and caring for. And there can be absolutely no holding back and embarrassment. When it comes to libido, this is one thing that both of us really found people coming and talking to us about. And a lot of women saying that they'd lost all libido, that they're absolutely no interest in having sex, but they had to. And it's concern. That the blue pill seemed to solve the problem for men.
Viagra.
Seemed to solve the problem for men. But women struggled. In fact, when pharmaceuticals come and ask me what's next for women, I said, give us something great for libido. But what we have started doing, and this is based upon evidence, we know that androgens are necessary, and androgens do have a role to play when it comes to libido. We don't really have the absolute evidence of how much, what, who benefits and who doesn't. But in cases who have this particular complaint, we have now started using transdermal androgens, transdermal testosterone. It seems to help. Now, how much of it is real and how much of it is placebo, I don't know. I think the truth lies somewhere between. But it's great because women suddenly start feeling better, more confident. A few other things have to happen. One is, of course, talking, listening, and counseling, because a lot of things come out. And some of these symptoms may reflect issues with the interpersonal relationships, and we should not hesitate helping women find help for that or coming out with that. And sometimes it's very interesting, Azmi, that sometimes I have to be the school teacher and lay ground rules, and something as silly as saying, okay, what do you all get the two of them and say, okay, what do you all think is a reasonable frequency of sex for you all to have? And generally they'll say, okay, maybe we could do it once a week. Fine. Then I'm laying down the law that you're going to have sex once a week from now on. So if you haven't had it by Saturday, have it on Sunday. Believe it or not, when you put couples up to it, they make that effort, they make the time, and I know things often get better. So it's got to be many different things. We have tried a small dose of sildenafil in women. You know, we are using it nowadays for everything from improving endometrial blood flow.
Yes,
And
for infertility and IVF, I've used it for that.
Restriction. And for the want of anything better, I have used it in a few patients, and just a woman thinking that she's taking 25 milligrams of what helps the male helps her. So I know, but we still need some. There are a few very promising products which are in the pipeline, I'm told, which are waiting for FDA approval. And I think women need more help in this regard.
Yeah. I'm going to change the subject now. I'm going to ask about cardiovascular disease, because actually women get very worried about breast cancer. But I always tell patients breast cancer is about 6th on the list of things that will kill you. That, top of the list is cardiovascular disease. And Nozer, you have written about your own mother who had a triple vessel bypass at the age of 55, and you gave her HRT, and presumably you gave her oral HRT. This was over 25 years ago, and at that time it was supposed to be beneficial for coronary artery disease. But since then, we've had the HERS study, heart estrogen replacement study, which didn't show a benefit. Now, hormone therapy, if you look at the leaflet, I mean, it's actually contraindicated in women. What the contraindications is heart disease, cardiovascular, established coronary artery disease. And even in the UK today, we're giving transdermal estrogen with, much, trepidation, some misgiving, so can you talk us through this and what your thoughts are, and, why you did what you did?
I go back to the early 90s when Professor Studd was visiting India and hard selling HRT, and we were all gung-ho about it. And there was reportedly evidence, and it made sense. I mean, estrogen is what protects women when they're young. And it made sense that you could extend some of this protection. So in the innocence of those times, mom went through the, well, actually it was 4 blocks, 4 vessels, put her onto HRT, and then along came
Premarin?
It was Premarin back then. That's all we had. And along came the WHI, and obviously after a few years, I stopped it. Interestingly, 10 or 12 years later, maybe 15 years later, when she had some symptoms, we went back and she had an angio, and believe it or not, her coronaries were in a pristine condition. And I always said, partly because of a great cardiovascular surgeon, I don't know, maybe a little bit because of the estrogen she took and a very healthy lifestyle. So that was again an outlier. Would I do it today? Probably not, because of the information we have. But there are 2 issues here. The first issue is cardio protection, CVS protection. There is clear evidence to show that when used in a younger woman, what they call as that window of opportunity.
Yeah.
Hormone replacement therapy actually reduces all-cause mortality and mortality due to cardiovascular diseases. So you do have an extension of the protective function of estrogens for a few years earlier on, soon after they reach menopause, but a few years down the line, they lose this, and then the whole thing changes. Whether it helps many different ways, but we also know that estrogen itself can give you a pretty good lipid profile, and maybe that's one of the reasons why it protects. Would I use it in a patient who has proven or established cardiovascular disease? I would do it on a case-by-case basis. I would probably talk about alternatives first, and there are alternatives for everything. You've got alternatives for everything from vasomotor symptoms to your skin and your other symptoms, for put protecting the bone, mental health, and we just don't have to. But if you do decide that you want to use something for a short term, then I'd probably give them the lowest possible dose for the shortest possible time. Put her on monitoring, keep reminding her at every visit that she's special and she's different. And that's why you're kind of doing it with her, and try and get her off it as soon as possible, because we also live in a very real world, and this real world is also a medical legal world. And whenever you do anything about this, make sure that you are completely honest with your patient, and you've done your documentation of the fact that you all were both party to this decision. I think it's not an absolute no, but it would have to be very judicious use. Transdermal, I don't know whether transdermal is going to give her any more protection than oral when it comes to something like the heart. I mean, it may spare the liver, but at the end of the day, it's the level of estrogen in her system that's significant, and that you could probably control by giving her a lower dose of oral medication, or you could give her the transdermal medication.
And then what about women with a hormone-dependent cancer, like breast cancer, who are on hormone blockers? Because, women have really troublesome vasomotor symptoms, vaginal dryness. Women who've been prescribed tamoxifen or the aromatase inhibitors like letrozole and anastrozole. So what are your views on giving HRT, hormone therapy to these women who are suffering with these symptoms?
So, I mean, for hormone-dependent tumors, I think I would have to be just too courageous and daring, which I don't know whether it's the wise thing to do. So you have to, again, find alternatives for them. Whatever you do, you have to do in conjunction with the medical oncologist. And trust me, they would shoot down anything which even sounds like estrogen, not estrogen alone. But what I have used, again, sometimes they will still voice concern. Vaginal estrogens, because most of it is local, almost nothing leaks into circulation. And particularly if you're using something like estriol, which fortunately is still available to us, it's such a mild estrogen. You're giving it locally, it will give you the benefits, but make sure that you have the sign of the phytoestrogens. There are some medical oncologists who have a problem, but whatever evidence we have says that phytoestrogens probably do not have the same effect on the estrogen receptors for the breast and other areas, but it's got to be done in conjunction. And maybe that's where we probably have to take diet into account more than just medications. And the one thing that I as a gynecologist, I always tell a woman who's on medication following breast cancer is sometimes oncologists forget the uterus, and they go on and on with the medication. And something like tamoxifen can lead to endometrial hyperplasia. And in those situations, I remember years ago, I had used, it just made sense to me when my anesthetist's wife landed up with breast cancer, and on tamoxifen, she started developing endometrial hyperplasia. And we used the levonorgestrel intrauterine system. Made great sense to me, protected her, she kept it. And a few years later, we took it out, and then she had a second pregnancy. Sometimes controversial, particularly if you've got progesterone receptor positive lesions. But I believe that the levonorgestrel intrauterine system really leaks such a small dose of progesterone into circulation that generally I would consider it safe. But any of these things have to be done in conjunction with who is now her primary physician, and that's the medical oncologist or the surgical oncologist. But I wouldn't hesitate to use the uterine delivery system or a vaginal delivery system.
That's actually contraindicated in women with the ER positive, PR positive breast cancers. But the other thing with tamoxifen is that it's difficult to interpret the endometrial lining thickness, because you have that funny shape, and there's a little bit of fluid collection around that and often, you get a very worrying picture on ultrasound, or the radiologist cannot make a proper proper judgment, and they end up having a hysteroscopy anyway. That's one of the big problems also with tamoxifen, is the interpretation, because it changes the character of the endometrium. And that's reflected in the scan.
True.
But, you know, as you said, HRT deals very effectively with vasomotor symptoms, but the more refractory symptoms that women want addressed are sleep and weight gain and mood. So they'll come and they'll say, especially because NICE has said now that, and you know, fair dues, that the women often get mood changes. You know, we spoke about that at the beginning of this interview, linked with the perimenopause, menopause transition. And a lot of them went to their GPs and they were given antidepressants. And NICE has said that for mood disturbances which arise at the time of the transition or around the time of the menopause, you know, consider giving HRT. So a lot of women are coming sort of in their sort of at the time of transition, you know, 45 plus, saying, I'm getting mood changes. They don't really have the vasomotor symptoms, or they've got some vasomotor symptoms. You give them the HRT, there's no reason why not to. And they say, yeah, I'm better in terms of the hot flushes, night sweats, but I'm not necessarily sleeping better, and my mood is, and I'm still not able to lose weight. And, you know, how do you manage them? Because they are very frustrated. They want something done about it.
So firstly, you're right. I think in women who come with expectations, HRT probably would be the first line. And there's no doubt that in many women, HRT will induce a feeling of well-being. The mere fact that here's a woman who's, I always joke that, you know, a woman who's suffering hot flushes, who's put on estrogen therapy, HRT, considers her doctor some kind of a magician. And I always say the magic is really in the prop. That's the HRT, but they are just transformed within the first few weeks. When they are sleeping better, they are feeling better. When they are feeling better, they're suddenly in a better mood. I mean, everything seems, the world seems to be brighter. But this wouldn't be there for everyone. And then there would have to be different strategies. Weight is always going to be an issue. And I'm going to then call upon someone like Shonali to help us out with that. As I've always told women, you are going to struggle with weight. There are changes in your metabolism. They say, but I do everything I did before. I eat the same. I exercise the same. What's happening? I say, no, but there's some ways that you have changed, and you have to change whatever you do, whether it's your diet or exercise, to match this time in your life. So weight is going to be an effort. You deal with the weight, you seek out help. And I've always believed that without any kind of condemnation or body shaming, the involvement of a great dietitian, someone who gives advice, a nutritionist really goes a long way. Sleep is the tough one, but very often if the night sweats have been taken care of, they start sleeping a little better. But in situations, and when it comes to flushes which are not responding, or again, we spoke about the contraindications maybe to HRT when you have hormone dependent tumors. We have got alternatives. You have got clonidine, you have got gabapentin, you've got and for moods, I mean, let's face it, fluoxetine would definitely be an add-on if your primary therapy hasn't worked. And SSRIs and SNRIs both have a definite role to play. But what I would always tell my patients is, let's go with one thing at a time. Let's give that one thing time to work. Let's meet after 1 month. Let's review your symptoms and let's see whether we need to add anything on. Shonali, wait.
Yeah, I believe that one is with food, especially if you take off their trigger foods, which are going to cause these issues. Like, again, we come back to sugar, you come back to stimulants, excessive use of alcohol, because women do tend to go towards sugar. So I'm realizing that a lot of women in their perimenopausal years also start drinking a lot. You know, they are having a lot of wine, for example. It becomes their mainstay. Every evening that's happening, and that's not necessarily great for you, you know. So moderating that, keeping in mind that you're not pushing yourself with empty carbohydrates, you know, you're not going towards the white carbs all the time. You're putting in a good whole grain in the day. You're sticking to a good diet, which has nice lean protein, leafy greens, lots of leafy greens. We neglect those. And of course, helping them with some plant-based adaptogens as well. I work with a lot of that stuff as well. You know, like you bring in tulsi, you bring in holy basil, all right? You bring in lavender into their day. You let them use, many times I've told them, and this has really worked, 5-HTP. You know, it's just taking that one.
5-hydroxytryptophan.
Yes,
Tryptophan, isn't
yes,
it?
yes. It's
Yeah.
worked wonders for many women who have had sleep issues and who have had, mood issues and anxiety issues. That works really well. So, helping them through this time with adaptogens, with the right diet, and keeping their brain stable, their sugar stable with good whole grain, that helps them go through this time much better. And the weight, of course, the one single thing I can say is if you can keep exercising and not neglect that, and you can keep eating right and be relentless about it. Women often, they don't do things in these years they have to be super focused. So it has to be really getting up, and it's like getting up and doing the same thing every day. You are exercising, you are eating right, just every single day through your perimenopause till you hit menopause, and you go through menopause, and then doing it after that. I think that really helps you.
Yeah, excellent. I agree.
Asmi, the interesting thing about writing the book was that the medical part we had to be very, very evidence-based, but Shonali brings this whole knowledge and Ayurveda, which sometimes is not what we are very aware of. And the whole section 3 is Shonali's section with diet and 20 pages of recipes, but exercise. Like, for example,
yes, the yoga asanas and all that.
Yoga,
that was
when
good
people
because...
go through, I've seen, I remember I used to go to Dr. Nozer, and I used to have, let's say, prolactin, which was high because I was really super stressed. And he'd say, take something. And I was just against medicine all the time. And I'd say, no, I'd be fine. I'll go home and do my inversions and I'll be okay. And then I'd come back later and it'd be my tests were normal. I'd say, what did you do? And I'd say, oh, I did these inversions. So many times in my interaction with him, I've just done exactly what I think was right. And I fixed myself with, like just doing what I was doing, eating right and just doing my yoga and, staying off trigger foods, and everything worked out.
It makes sense because people say, well, I've done previously, I could lose weight whenever I went on this Slimming World or Weight Watchers. That's what we've got here. Now I can't. So, and I always say that if you want a different result, you have to do something different.
Yeah.
And so long as it's not dangerous, the good thing is that you're not advising expensive supplements, the things like melatonin people buy over the counter, tryptophan, magnesium. And often these, when you say placebo has a very powerful effect. You talk about lavender. Lavender has an effect on sleep. This is basically aromatherapy.
Right, frankincense and lavender, those are the two things that became my evening mainstays. Like, I used to always start my evening by rubbing frankincense. And then when I'd wind down for bed, taking in lavender in diffuser or putting it. Really
more than anything, they have a calming effect. And I think the fact that when you're saying this, what happens is not so much the tryptophan. I mean, I'm sure that you've had experience with it. But the fact that the woman is doing a routine, automatically, a lot of us have very disorganized lives. And then we complain of stress and we complain of all sorts of things. But if you actually see it requires some organization, and that in itself has a calming effect on mood, then you're eating differently and you're going to see different results. You have to do something different if you want to get, to someplace else. But we're running on. So Nozer, I wanted to come to the last bit, and I wanted to ask, what is your view on testing for hormone levels? Because patients still come, despite NICE saying that, you don't need to test for, to over 45, you don't have to because it's fairly obvious. And plus the hormone levels fluctuate. Women often ask, can you give me a test for menopause? And except in POI, premature, ovarian insufficiency. And would you use, say, supposing somebody came to you and said that I'm not getting the benefit I thought I should get, would you consider using the blood testing, bearing in mind that for us, we are using NHS resources, it's taxpayer funded, that's personally funded. There's an expense as well. Would you consider increasing your, dose of HRT using levels as a marker? And going back to the first question, do you use it? Do you do a blood test to diagnose it?
So while according to guidelines, you absolutely don't need to do a blood test to diagnose menopause. In practice, we do sometimes do things differently. Now, where we have maybe an advantage over people working in the UK is most of these tests are available, affordable, and self-funded. And sometimes to make a woman understand where she is, particularly when she's in the perimenopause and things are becoming a little irregular, or when she's having certain symptoms, then maybe an FSH and an E2 level might be one way of carrying on the conversation and telling her where she is. But do you need it? According to guidelines, you don't. You can just kind of ask her, go by her symptoms, wait till she's 1 or 2 years, whatever, into amenorrhea, and then say, now you've reached menopause. So no, I don't think you have to do it. But in my practice, yes, I do it quite often when I have to work with patients, and it really gives me something to talk to them about. Your FSH is 25, your estradiol levels are 26, and maybe now this is what we need to do. Do I use it to monitor therapy? No, I go by symptoms. Do I use it to find out if I'm giving her enough estrogens? No, I let my symptoms guide me on that front. So most of the time I will use it is earlier on, when we are trying to decide where we are. If she thinks she's in the perimenopause, but she's got an absolutely normal FSH and E2, I can tell her, you know what, we are going through different kinds of disturbances now. Let's deal with the menstrual issues, the symptoms. Your menopause is still many, many years away. A family history often helps. I'm convinced that finding the woman's, her mother's age at menopause is a fairly good guide. Guide of where she is. And every patient of mine has her mother's age at menopause documented, and it's kind of a lighthouse for us that we are sailing towards, and is kind of helping us out. So I ask the mother's age. I do use it not infrequently to have this conversation when she's in her mid-40s, to see where she is and tell her, no, you may think you have symptoms, but from what your levels are, we still are many years away from menopause, and you don't need to worry. And now let's deal with your oligomenorrhea or whatever it is. But no, I do not do hormone levels in women who are on treatment. I just, you titrate treatment according to her needs and her symptoms, and not according to hormone levels.
Oh, that's excellent. And finally, Shonali, before we throw it open to the audience to ask both of you questions, I'm sure they have a lot. Just tell us a little bit about the gut microbiome, because that's what everyone now is talking about, this, the gut health, and gut health affects your brain, it affects your heart, it affects your immune system. Can you tell us a little bit about?
So I think the awareness that there were these microorganisms that existed, but the reason why we didn't talk too much about it was because traditionally we were eating right, and then somewhere the systems broke down, and we got exposed to so much stuff out there that we just started eating badly and breaking down the whole microbiome system that we have. And that's when inflammation started, leaky gut started, and all those things started. And then conversation started happening around the gut microbiome. So I feel that if we just dial it back and go back to eating really high fiber foods, keeping away from the trigger foods, things like sugar, dairy, white flour, processed, refined, empty sugars, by that I mean empty carbs, and focusing on, bringing in the tradition of fermentation, fermenting, because that's kimchis and sauerkrauts and pressed salads and pickles, and these things really help. And every tradition has something fermented, it's like the Indian tradition has it, in the West, there's plenty. Of course, there's a certain type of fermentation. I talk about it in the book called lactic acid bacterial fermentation. So those kind of foods, which are typically kimchi and sauerkrauts, that's a different kind of fermentation. So you're getting all this diverse bacteria coming in, and that's supporting your gut and then supporting all the other systems, because it all starts there. If you have a sluggish liver because of bad eating that you've done over in your life, or you've consumed too much alcohol, or your liver's lethargic, then you need to keep the liver pathways clean, especially for women at this time, because all that excess estrogen needs to be broken down there, and then you need to throw it out of your system. So therefore you need to have your liver clean. Therefore, just focusing on like a greens juice helps the liver get flushed, or focusing on a lot of greens. Barley, it's very good for the liver. The liver loves sour foods. Just focusing on lime, focusing on radish, focusing on things which are bitter, mustard leaves. These are very good for the liver. So for women, it's very essential they do that. They keep their liver pathways clean and they focus on their gut, because that's going to help them also excrete all those hormonal wastes that we need to do at this time. And focusing on crucifers and the brassica group, like your cauliflower and your cabbage and, Brussels sprouts and kale. These are very good because we all know that they have certain compounds in them, which also help you with estrogen movement, excess estrogen movement out of the body. So yes, food becomes very integral, and the gut becomes the seat of everything. In Ayurveda, we say Agni, which is the fire. So it's like really where everything happens. If you're going to have that clean gut and you're going to stay healthy, then you're going to prevent inflammation from happening. Therefore, then if you're going to at this time go into a lot of bone and joint issues, you're going to save yourself from that. And other issues that you're going to be dealing with, because I've seen, because of where we are, we're all dealing with comorbidities, so people are coming with not one condition, they're coming with many conditions at one time. And it's all stemming from the fact that, their diet somewhere has weakened and they've got this inflammation going on. They've had a gut condition, weak gut, so to say, and they're facing it. So yeah, it's very important. I focus on it a lot. In fact, it becomes I start with the gut and then get into everything else. I feel if you can fix it, you'll fix everything.
It's fascinating. So I think that brings us to the end of all the questions I've thrown at you. And I think people will want to ask questions. So anyone who wants to can unmute themselves. I'm going to ask Lalita. Lalita is the chairman of our local integrated care service for East Berkshire, Surrey, Frimley Health, and she's an ex-gynecologist herself. So Lalita, you've been messaging me. So would you like to start off?
Yeah, thank you, Azmi. Fascinating. I'm in the car, so I hope there's not a lot of disturbance. So really, really great conversation with both of them. And listening to Ayurveda took me back to my roots, where I can remember my mom and dad using Ayurvedic medicines and principles, but you're so right that we seem to have forgotten all of it. Along the lines, I also wanted to ask you, in terms of alternatives, you listed so many of them beautifully for us. Are you using any non-pharmacological alternatives for the woman who comes with a bit of hot flush, a night sweats kind of syndrome?
Me or Doc? You're asking me?
Yeah, either of you, really. So, it's not the clonidines, etc. Is there anything else? Because in UK, of course, if a woman goes to places like Holland and Barrett, she can get things like red clover and so on. But it'd be great to have your views on all of this.
So interestingly, we do as well. The pharmaceutical industry is too clever to let go of any part of its market. So when they lose people who can't take traditional HRT, they'll always have nutraceuticals. And we do have nutraceuticals in India in a big way. Yes, we use preparations with isoflavones. Many of them are soy-based, and so Shonali would rather do it with the diet. Black cohosh, red clover. We have most of these preparations available in the form of medication, and we do use them. And in fact, we use them, I would say, more and more often because women will come back to us. Many women would be a little hesitant because of all that they read about menopause hormone therapy, and will request alternatives, and would do reasonably well with them.
Yeah.
I would have no problem prescribing them if that's something the woman is comfortable with. I do know that when it comes to significant symptoms, they probably will not give you the same effect as conventional HRT.
But I have recommended, because I work very closely with an Ayurvedic practitioner as well. We've mentioned him in the book, and my go-to is him. So if I find a case of mine that needs an intervention, then I do end up describing the symptoms to him, and then he'll give me something from his repertoire of Ayurvedic based herbs, which I've helped my clients with. But I always go with his recommendation. So I'll always talk to him about the case and say, she's not wanting to lean on anything, but she's okay doing adaptogens. And then what do we suggest? And you'll find that there are many companies now in India, like India Organics is doing a range for women of Amalaki and Shatavari and, all these other adaptogens, which really help women during this time. So I do try to push them in that direction.
Thank you. Thank you.
What about anyone else? You can just unmute yourselves.
There was a question from my friend Atul about Tebalone in ER/PR breast cancer. So interestingly, when we first started using Tebalone a long time ago, we were given the impression that Tebalone completely spared the breast and the endometrium. But since then, evidence is otherwise. There is an association with a very, very small increase in breast cancer. I think the relative risk is like
study spoke about the fact that there was
about
an
1.4, which is it's like 1.5 times the risk. So again, I think in an established breast cancer, we'd probably be better off looking at other alternatives. And Prema, thank you so much for your message.
No, I seriously am looking forward to the book.
Thank you.
I think my postgraduates will also benefit greatly from it.
Thank you.
Yeah, I think in the UK, we still have a problem in that now we're trying to educate GP trainees about menopause, and most of them are quite switched on. But I don't believe that the obs and gynae trainees receive it as part of their core training. That is a huge problem. So it's it's a very useful thing to have. It's a very useful thing to have, especially in India. I don't think, Sharmin, did you get any as part of your postgraduate training? You've just completed, haven't you? Sharmin? Yeah.
No, Dr. Azmi, I did not. No, I did not. It's not part of the postgraduate curriculum as such. Separately.
Right, okay. Yeah, Monique is asking when will the book be available? It already is on Amazon. So I've just
it's on, I think the Kindle version is out on Amazon, and
you can get the
hard copy.
Yes, you can.
Oh,
you can. I checked yesterday when I spoke through.
Yeah, they said December.
Yeah, so I think especially in India, where there's such a big gap in the market, and I found it useful as well because, as I said, things like you've been using oral, you've been using Tebalone, you've been using things, and these are things that because after the WHI, HRT fell into disrepute. Then when we started using it, it was transdermal, micronized progesterone. Now there's a shortage, and women are chopping and changing between various preparations. And It's like, okay, if you give Tibolone, oh my God, now she's 55, she'll have to stop it when she's 60. So it's nice to see people with series of patients where they're actually using it. And they're saying, well, I accept that this is not RCT evidence, but as I said to you, Nozer, before, that randomized controlled trials are not real life trials because they exclude X population. You see, they'll take the healthiest group of people, they'll try and match them absolutely with their controls, with the controls. And the thing is, when you see patients in practice, no two women are the same. You can't, this is not clinical practice, daily practice. If you have observational data, they'll say, well, that's hypothesis generating, and you can't say that this is true evidence. So somewhere you've got to find some ground, and the Tibolone I find is very, very helpful when people get breast tenderness. Some women will just respond to estrogen with breast tenderness, and it's persistent. And sometimes Tibolone is quite nice for those people. It's nice because testosterone is not licensed on formularies here. So the thing is, you can, if you are a specialist, I can prescribe it, and people who've got, who've got confidence with it can. But a lot of areas, because it's all publicly funded and you have the formulary, they can't give it. And then Tibolone is an option. It's weakly androgenic, but
Right.
if you mentioned that, Nozer, that actually, if you look at the studies, less than 1% of sexual pleasure, satisfaction, orgasm is actually linked directly to testosterone. It's only important when you look at two main things: relationships and psychotropic medications, like antidepressants and other things. So, and sometimes, yes, the people have to actually start to do it. They just look at each other, decide they don't feel like it, and it's not going to happen.
Also, I'm using a lot of for women, especially during this time, there's a lot of collagen that I'm using. So I teach them how to do, for their bones and for their cartilage and their joints, doing that. And it's also helping their skin, and it's also helping their hair, so we're teaching them how to make it, and we're also giving it to them orally if they need it. That also, as an added supplement during this time, it really helps them.
And that's something we can't sort of advise as
you can't, but
doctors, but
in terms of food preparations, like if you do a good bone broth, for example, it's full of collagen. So I've actually given a recipe, I think, in the book of bone broth. It's really, really beneficial for women at this time, if you're a non-vegetarian.
Okay, I mean that's interesting to know, because it's better than a woman coming to us asking for her HRT to be bumped up again and again and again. Which is what we're having problems with. We've got Stephanie. Did you want to say anything? And Suzanne, you are very active on the group, both of you. So I just wondered whether you had any contributions. Stephanie is the specialist nurse who does a lot of the HRT work locally in Maidenhead. So she's always very active. I wonder whether either of you had anything. No? I think you've answered everything very, very patiently, and it was extremely, extremely helpful. So thank you, Nozer. Thank you, Shonali. Do you want to show a picture of hold up your book before everyone goes so they know what it looks like?
And thank you, Azmi. Azmi was always there, giving us inputs, guidance, telling us things that may not have strictly been evidence-based. Thanks, Azmi, and giving us a fabulous endorsement for a book. So this is our book.
It's called Finding Your Balance.
Yes, and we really worked with Penguin Random House. They gave us ideas for the cover, and we decided that rather than carrying a picture of the authors, we like this much better. This metamorphosis of a flower which fades and breaks up and then comes together to this beautiful butterfly. And again, Penguin pushed us to give them a non-medical title, and we brainstormed all evening and came up with Finding Your Balance, because that's what we believe women need to do at this time of their lives.
A message from Stephanie, that was super helpful. Thank you. So, and Atul has said it's a brilliant session. So thank you everyone for coming. Thank you, Lalita. I know you probably attend 100 Zoom meetings a day.
Thank you, Asmi. Thank you, everyone.
Thank you, everyone.
It's been a pleasure.
Fabulous. Thank you so much.
Thank you.
Okay. Okay. Bye, everyone. So
Bye-bye.
I'm going to end the meeting. Yeah.
Asmi, thank you for organizing this, Asmi.
No. You're very welcome. Lalita and I go back a long way, Nozer. Lalita is head of the integrated care service, a big lady now, moved out of hospital medicine and sort of gives everyone directives on what to do now. So all the policies, all the hospital admissions, everything, all the crisis in East Berkshire and Surrey is handled by her.
Wow. Thank you
Thank
so
you.
much.
I'm buying this book tonight.
Thank you so much.
Thank you for this helpful meeting.
Okay.
Bye.
Bye-bye.
Bye, everyone. Bye-bye. Thank you for coming on. Okay. I think only a few of us are left. So I think we can, if anyone wants to unmute themselves, they can. But thanks, Nozer. That was absolutely terrific. I'll end it and then speak because we'll have to edit the recording otherwise.
Yeah. Thank you. And